Welcome and thanks for joining us. I'm Yael, Ksander Communications Director for the City of Bloomington, and I'm so glad you've tuned in for today's conversation. Since the 1990s, communities across the country have been grappling with the effects of heroin and opioid addiction, and Bloomington, of course, is no exception. Between 1999 and 2017, according to some figures, almost 218,000 people died in the U.S. from overdoses related to prescription opioids, according to the U.S. Centers on Disease Control and Prevention. Today, we are very fortunate to have with us the author and journalist Sam Quinones with us to share the observations he made in writing Dreamland, the true tale of the true tale of America's opiate epidemic, and that book won the 2016 National Book Critics Circle Award for Nonfiction. And I should mention that Mr. Quinones, I'm so sorry. I should mention that Mr. Quinones' visit to Bloomington has been made possible through Centerstone, the City of Bloomington and the IU responding to the Addictions Crisis Grand Challenge Initiative. Talk about a mouthful. Mr. Quinones will be speaking this evening at the Buskirk-Chumley Theater at 6:30. He has a full day, and we're so glad that you could be here with us.
It's my pleasure. Thank you all for having me. Appreciate it.
And I should also mention that we are fortunate to be joined by folks who've had boots on the ground here in Bloomington with regard to this crisis for many years. With us to my right is Linda Grove Paul, Vice President of Adult Services for Centerstone, the healthcare organization specializing in mental health care, addiction treatment, and community education here in Bloomington. Also from Centerstone to my left, recovery specialist Tammy Hooten, who is a person with lived experience. She says she is a grateful recovering addict who has currently 2.5 years of sobriety. Awesome. Her journey has not been easy, but helping to start the Centerstone City of Bloomington Parks and Rec employment partnership allowed her in early recovery to have meaningful employment and a sense of purpose and accomplishment. And it's great to know that you've gone from being one of the first members of the crew to developing the program in a leadership position at Centerstone. And last but not least, from the City of Bloomington, Beverly Calender-Anderson, the director of our Community and Family Resources Department. She's worked closely with our public safety departments on the front lines of the opiate issue here in Bloomington and provided services to those affected. Welcome all of you. Excited about this conversation. We're going to have to speak really quickly to get in all of the topics that we want to discuss. I'm really looking forward to bringing together the firsthand experience you all have dealing with this issue in Bloomington with your tremendous reporting on, as you put it on one page, the way two separate commercial enterprises managed to exert, quote, a catastrophic synergy. I thought that was a pretty great description that produced the juggernaut that is the opiate crisis. Your book came out in 2015, but it's strangely relevant. Now, some of us are only waking up to this issue.
Right.
I mean, we're just hearing on the news last week that 4 more states have filed lawsuits against Purdue Pharma,
Sure.
The makers of OxyContin. And I would love for you to just catch us up here. For those who haven't read this book, give us a thumbnail sketch about Purdue, about the changing philosophy about pain.
Sure.
And
Well, there's a lot there.
All that.
Basically, this epidemic begins because, in very different ways than past drug problems, the supply is provided not by drug traffickers or drug peddlers or mafias. It's provided really by doctors overprescribing, in my opinion, overprescribing narcotic painkillers for all manner of pain in long periods of time, at ever escalating doses. A lot of that creates a black market. But they were pushed, I think, cajoled, pressured by pharmaceutical companies and pain specialists who believe that these pills could solve pain in America, kind of a quixotic idea that this was like a new day, and together this economic force changed prescribing habits across America, and were adopted in medical schools and so on. And so you get all these people and deciding that we could prescribe these pills for long periods of time, ever escalating doses without really any risk if the person was a pain patient. And for some people that's true. For other people that's not true. It does depend on who the person is, what the background for the person is, the environment in which the person lives, variety of things like that, and also the dose and the extent to which the person is exposed to these pills. Some people don't have a problem with them in very short doses. A lot of people don't have a problem in very short doses and small doses. The longer you extend that, the higher the dose, the more you see people having problems. And the pharmaceutical companies were particularly involved in that, marketing these drugs as virtually non-addictive. And that was a big claim that Purdue had, that these pills can be used now with risk-free, doc. You don't have to worry about this, it's risk-free. Don't worry about the background of the patient. Don't worry if that patient has alcoholism in her family, or if that patient is also smoking marijuana, or what a variety of things, or whatever events might have been traumatic in their early childhood. Say none of that is worth really paying attention to, and so that got us to a point where we have an unprecedented amount of these pills being used for pain, and an unprecedented amount of prescribed medicine leaking out into what I consider to be black markets in most areas of the country. And so even people who get addicted not through having the pills prescribed to them are getting addicted to medicine that was prescribed to somebody. So at high school parties, you find often that the pills replace beer, and pot is like the go-to kind of experimental drug. Very dangerous to be doing that.
You mentioned also the really important role that the economy, the shifting economy played, especially in the so-called Rust Belt.
Well, there are certain areas, sure, that have been left behind. What this thing did, I think, is show us the effects of globalization in a very stark way. It showed us areas of the country that have been left behind. Something that we should have realized decades earlier. In a lot of communities were kind of crying out for help for some time. This, in some ways, kind of highlighted that to some degree, I would say. But it's not just in economically disadvantaged or devastated areas that this is taking place. The interesting thing about this epidemic is that it goes to some of the best off communities, suburbs not far from here, near around Indianapolis, that are really the beneficiaries of previous, 30, 40 years of economic expansion. Those folks too. So it's not the economic response, an economic answer to all this is not, I think, the crucial one. The crucial one is our own isolation. And what is the common denominator of all these communities is a kind of a social, economic, political, cultural, professional isolation in so many ways. And I think that's what brought us to the point where I ended my book. Then some other things happened after that.
Yeah, also in the book, important to just bring everyone up to speed, you also describe the second large commercial enterprise responsible here for this addiction.
And what has happened, I think, is that all this was done as if it were in a little vacuum. Like this, we could do this and there's no other world trend that would affect this. And in fact, we had already seen a historic change in our heroin markets. Nobody noticed except for the DEA because not a lot of people were doing heroin anymore, right?
Back in the 70s.
The Mexican and Colombian cartels and drug trafficking groups shifted that, and they took over the heroin market in our country from the heroin that used to come from the Far East, from Burma and Turkey and Thailand and so on, because that stuff got here very expensive and very weak. And they could bring it in cheaper and more potent and in time. And so they just essentially crowded out all that Far Eastern heroin. All that was essentially a fact on the ground by the time pharmaceutical companies began promoting pain pills along with pain specialists, and we as Americans honestly began demanding it as health consumers. We demanded, doc, fix me. When the doc said, well, part of your pain is, it really has more to do with exercise and eating better and getting outside and being among other people and a variety of wellness solutions. A lot of Americans say, no, you fix it, give me the easy. And that was really a big part of what went on. All of this kind of combines and then is overlaid on a culture of self-gratification, but then also on this little known fact that our heroin was now on the path to becoming cheaper and more potent than ever, and that becomes the replacement for pills. When pills get too expensive in the black market, you switch to heroin. That would not have happened in the 1970s because the heroin was coming from the Far East, got here very expensive, relatively expensive, I would say, and weak. It had been stepped on and cut numerous times, and so it was not the same kind of replacement as very cheap, very potent, very prevalent heroin coming up from Latin America, primarily Mexico.
Right, so it was really an emergent system because
there was all these things that kind of went into it, and that's what I found fascinating and wanted to reflect in the book, that I'm not much of a believer in the bogeyman theory of history, where you could point, that's the bad guy right there, like Snidely Whiplash, the mustache. It's more that there are a variety of factors going into these stories that we all need to take into effect, and if we don't, then we're going to design policies that probably will fail, be a waste of money, and leave people jaded, like nothing works, nothing will ever work. Well, things will work if we come at it from a kind of a community vantage point, that there are lots of ideas behind this that went into this, and lots of things that went into this, not just a few bad guys. So it's important to understand the role of pharmaceutical companies, but that's not all that went into this.
Yeah, the culture was receptive, and then of course
I think the more I got into this book, the more I realized we needed to be the change we want. So I stopped drinking sugary drinks. I don't drink like sodas and sweet teas anymore. I used to drink a fair amount of that. I began exercising. It's all about, a lot of this gets back to each of us taking personal accountability for our own response and saying that we have the ability to make the change we want to see, and it's important to do.
I'm so excited to bring everyone into our conversation and our audience. I'm happy to have folks watching. This is Facebook Live, a conversation with Sam Quinones. Sort of. Quinones. Oh my goodness. I've been saying it in my head the wrong way all this time. Sam, the author of Dreamland, The True Tale of America's Opiate Epidemic. And we'll be taking your questions here in a moment, but first I'm really anxious to bring in members of our community who have direct experience with the opiate epidemic locally. Would love to know from Beverly, from Linda, from Tammy, when you first became aware that things were changing here from your perspective as a clinician, etc.
Well, as a clinician, again, that's the best book I've ever read. It pulled together so many things as a person with boots on the ground that you'd seen happening in my 22 years in the field into one comprehensive narrative. So I really appreciated that. And then it made it accessible to everyone, because people would scratch their heads and say, what's happened? How did this happen? And you do such a wonderful job of talking about the many factors. Pain is the fifth vital sign. That idea that in our country we're under managing pain and looking for that quick fix. Saw those pieces, but
that was a new idea, though, wasn't it?
At the time,
and still kind of a one that doesn't have universal acceptance, right?
And our accrediting body, said to us, "You were under-treating people with pain. You need to send more people off to the hospital or the doctors." But what I'll say from my experience is, 22 years ago when I first started in the field, probably 90 to 95% of the clients that we had were men, and they were alcohol was really what we were treating them for. And the women and there was some cocaine and kind of dabbling in heroin, but for the most part it was alcoholism. And then women who really started to come in, it was women on pills. So primarily, and Tammy and I were talking about this a little bit earlier, and she was saying, kind of her experience is the same, but primarily people came in and went and used the pills in large part because of trauma. And they found not only physically did that help, that the medication helped, but it also very much emotionally helped them in coping. And then over the years that began to change. Men, started to use pills more. Tammy can talk about that a little bit more. But then, the real change was about 2013, 14. When basically pill mill legislation went through, and then access to medication from our pill mills locally pretty much got cut off.
Pill mill is a word that confused me for a long time, so I think it bears, along with opiate, I feel like there's some term definition we need to do here.
Okay.
A pill mill is not the factory. A pill mill is the prescribing place. Can you guys describe what that term means?
So a pill mill here, in Bloomington, we had 2 doctors, 2 physicians that everybody that I met with knew how to go get scripts. And one they referred to as the Candyman. So any opiate,
the Candyman.
And any opiate, any benzo, any kind of medication that you wanted or needed, you could get. In fact, when this person ended up giving up his license, he had over 20,000 pre-signed scripts. He was giving out about 120 a day.
And that happens all over the country.
Right,
that was
exactly.
very common, and that this led to the kind of the commercialization of pain management, so that doctors were getting very used to just being prescription mills, essentially is what they were.
Yeah, 5-minute appointments.
Oh yeah, didn't take long. You just pay like $90, $80, whatever the fee is. You go
All of
back
it for
there.
cash.
Yeah, it was always cash. You could not. If I had insurance, I would just use cash for that appointment. And then you just go back there and tell them what you want. It's not what do you need. Nothing about you. It's what you want.
There was no pain
There's no talk.
diagnosis. There was no MRIs. There was no attention. Gee, what have you tried lately? Let's see if we try this again. Try something else. It was just strict.
Just strict. Go back there and then you walk out with 4 prescriptions. Stuff that don't go together. Methadone and Xanax don't go together. Methadone, Xanax, and hydrocodone don't go together.
That's, in fact, it's quite dangerous.
Yes.
It is. It's very dangerous, but that's what I walked out with, and that's what everybody else walks out with, and it's sad and unfortunate.
And then we read in your book that not only was this happening for individual patients, but predatory folks were going in and patient shopping and finding folks like you to go in, paying for your doctor visit, and then taking, as a result, half your prescriptions to sell.
And that happened in a lot of these areas. I think probably happened in Indiana, certainly Kentucky, West Virginia, Ohio. I've heard. And then a lot of pain clinics open up in Florida in the mid-2000s. So there's these caravans that go down, guys hiring addicts, taking 6 or 8, 10 addicts down to Florida, getting them all their prescriptions, taking half their pills. But I want to say one thing about that. That is true, that phenomenon led to an enormous part of the increased supply, but we would not be in this problem today if that's all that it was. I think it was really the widespread adoption by doctors all across the country, well-meaning, not quacks, not scandalous folks who prescribed this just as a routine to almost everything that came up that was part of it. They were not necessarily pill mills, they were just doctors who bought into this, as so many did, and that is what accounts for the enormous supply every year. These guys weren't bad, and they were easy to find and easy to point out, and you could find them in every region. So 2 or 3 docs that were just scandals, but that's not where the massive supply came from.
Well, they bought into the notion that there was no repercussion. I mean, that there wasn't going to be an addiction afterwards. And I was going to say, we first came into this from the city's standpoint about 3 years ago, 3.5 years ago. We started the Safety, Civility, and Justice Initiative, and we were seeing the ramifications of what happened, because we were seeing more and more people who were experiencing homelessness downtown, and then there were mental health issues, there were addiction issues, and so when we went through to try and address some of those issues, well, one of the first things I got was, you need to read Dreamland. And there were several people that said, have you read this book, have you read this book? And so I did.
Thank you, Beverly.
Actually, I started reading it and I couldn't put it down, so I started listening to it. But it helped me contextualize what was happening too. And so as somebody who is not a clinician, coming into it, it really did help put some of this into perspective and understand that this was not, and it wasn't a one-pronged issue. I appreciated you saying, you know, that it's a community issue. The solution to it is not, okay, now we're going to get everybody that is addicted clean, you know, and that's not it. And so we have in our community lots of different people working on this issue, whether it's from the city or the county, the health department, the harm reduction folks. I mean, so we're all, you know, working together on it, or trying to work together to address the issue.
Yeah, we've talked a lot about the pharmaceuticals. Now, as far as the heroin is concerned, I'm curious about when you all here in Bloomington started seeing that show up. I know I came to town in 1998, and I was surprised when I got here from Virginia to hear about people I knew using heroin.
Mm-hmm.
I mean, I had not heard about that for decades. You know, it was something kind of legendary.
Yeah, I would say my experience, and then I want Tammy to talk a little bit about her experience, but my experience as a clinician was that there were pockets of heroin in kind of the late 90s, the early 2000s, but you didn't see massive amounts of people who were using it. Primarily, it was pills, again, cocaine. I mean, you know, it was just kind of on the backside of the crack epidemic. You still had some people that were using crack, and then meth really started to come on the scene. Right. And meth was actually much worse than our heroin problem in this location until probably the last 5 years or so.
Yeah, I agree with that. I know that I was went to doctors and got medicine, and then years of doing that, you know, and then when doctors get shut down, that was about 2009. That's when I started using heroin. Just because there was nowhere to go. Like, I went to, the doctors got shut down here, and I remembered making a few trips like to Indianapolis, stuff like that, but nothing that lasts because they would get shut down too. So that's when I was introduced to heroin. And
where did you get it?
From local, just people that I ran into and met.
Where did they get it?
They got out of town. That's right.
Yeah,
did they go to Indianapolis?
Chicago, Detroit,
Cleveland, Detroit.
Yes, that's right. A lot of them came in because they knew that they're going to make money there.
I said, yeah.
Yeah, so,
And you were saying that the markets that they were in weren't profitable, so they would come to Bloomington because they knew that there really weren't big-time dealers in this community.
Yeah, the thing is if you live there and everybody's selling it, you know what I'm saying, and you come here, they're gonna make money here.
Right.
And a lot of them said that, we're here because we're gonna make money, we can't sell there because there's too many of us.
Too much competition.
Yeah, there's too many of us, so, it's unfortunate they come here to make money off this town, and, you know.
I found a lot of small towns face that, where you find urban centers being the place where the dope ends up, but then very quickly they realize they can double their money, triple their money, and whatever, by going someplace else. Or what you also find is that users from those towns realize that if they just go to the big city, whatever it happens to be, the metro area that's closest, they can buy the dope, come back home, support their habit, and with no money spent, you know. Yeah. So it's that back and forth, I think, that you find that really ravaged a lot of smaller towns, just because of the so many people in those small towns were getting addicted. And Bloomington's one of them.
And the disposable income found in a college town too, I think, pushes that as well.
Oh yeah, no doubt, yeah.
Now I'm gonna say, like, our jails are so overcrowded. The jail here is so overcrowded because, and if you look at that, it's mainly people from around town that have came here and dealt. Like, the people that live here that are in jail are sleeping on the floor because we are housing so many people that's not even from here.
Yeah.
You know?
Yeah,
so
I
that
think that's a
shows
real
you right
misnomer
there.
of our jail population.
I mean, that shows right there what's coming in to, you know, to our Bloomington or whatever our towns. But yeah, it's definitely coming from other places and being brought here to make money.
But one of the reasons it's coming here is because in every place in the country, you have this phenomenon of people of excessive, I would say indiscriminate almost, prescribing of pain pills that created something that did not exist before. The reason they can sell for triple or whatever price in Bloomington or any other small towns because there's a lot of market there now. The supply helped create the demand, and now the demand is like on its own.
Yeah, when the supplier's gone, there's nowhere to go, so they know they can come in and make money, because
Yeah.
there's no more doctors that's gonna get medicine. My mom's in pain and she can't even get medicine.
Well, this is another problem.
Oh,
This
yeah.
is on the face.
Yeah,
That
it's
as a
sad.
country, it's like we can't find the middle. You know, we like go to
Yeah.
here to here. And one of the reasons I think for that, there's several reasons, and it's not good. It's not okay to say, well, tough luck, you just gotta go it alone now, you're on your
Yeah.
own. That's not okay. One of the reasons though for that is because one of the reasons we got going in all this is because insurance companies stopped reimbursing for treatment that didn't involve pain pills. And so a person with chronic pain would have opioids and then acupuncture and exercise and physical therapy and cognitive behavioral therapy, a variety of things, and then all together, all reimbursed, and all together, so the doctor would be able to kind of like adjust these treatments. Little by little, the pills take over, and there's no more insurance reimbursement. And so a lot of folks got in with chronic pain, became diagnosed, and then treated with just pills, and they are up in very high levels. And we have spent a lot of time decreasing the supply, which is a good thing, very good thing, it's an essential thing, but we have not worked on replacing treatment,
Yeah.
giving other treatment replacements.
You can't take it away and not fill it with something.
Well, if you do, then
Then
you
you're getting what you
feed the black market
Yeah,
again. So you get
that's what I'm
people
saying.
going there, or in excruciating pain, life-ending pain. And it's like we, as a culture, we have not been able to find the happy medium. And one pain patient told me, he said, a chronic pain patient told me, it's all or nothing with us. It's always pills or nothing at all. And I think we need to get to this point, and a big part of that, frankly, is the role that insurance companies play in the solution. They need to understand that it's not just that they write prescription for physical therapy, they also have to write for cognitive behavioral thinking, all these different things all at the same time, and reimburse for all of them.
Yeah, I agree with that.
Which probably needs some re-education of our medical
Oh, yeah.
community.
Goodness.
Yeah.
Which is a whole different.
That's
Well, that's a big topic, but you're absolutely right. That our medical schools need to deal with this. It's so important.
I want to talk about some of those solutions here in the second half of our conversation. We've hit the halfway mark, and this is Facebook Live here with author Sam Quinones, author of Dreamland, The True Tale of America's Opiate Epidemic. He's here in town on a visit that's speaking tonight at 6:30 at the Buskirk Chumley, and his visit is sponsored by the city and Centerstone and IU. We're so glad to have you here, and so glad you stopped.
My pleasure. It's
stopped
really
by.
great being here.
It's fantastic. Also, we have Linda Grove Paul from Centerstone, Tammy Hooten from Centerstone, and also Beverly. Calender-Anderson from the city of Bloomington. I'm Yael. Ksander, please join us with your questions if you have any about the opiate problem in Bloomington or farther afield, and we love to entertain those. I would love to talk about treatment and solution and things that have worked, how we've grappled this on a national basis, and what's worked here. Obviously, what your research has shown us is that we are here battling global forces.
Yes, correct.
And it's a complex issue that requires a multi-pronged solution.
Correct.
So you told us about many things that have started to, sort of eat away at the problem a little bit. Some of changing the pain prescribing guidelines has changed,
Right.
although as we've mentioned, it's
But
gone
not
sort
in
of
conjunction with another equal change in prescribing reimbursement, reimbursement for pain and treatment.
right.
Yeah.
Yeah. So we've also got the enforcement side and we've got the treatment side. Maybe we can discuss what's worked and what's worked here. Linda.
Sure.
What's working?
Well, so, I think one of the biggest issues is, as we were talking about before, is just a misunderstanding about what addiction actually really is. You talked a little bit about, recognizing the vulnerability of people who have an addiction in their history, have exposure to certain kinds of substances, and I think for a long time, addiction really was not, it was considered a moral failing. This idea that, just we need to pull ourselves up by our bootstraps. We need that instant gratification. You need a pill. You need, a quick fix. And as we said, it is a very complicated issue, and no two people respond the same. And treatment really has changed in that regard, because it used to be fairly prescriptive, rigid,
Punitive.
abstinence only. And a large part that came along with just kind of the criminal justice partnerships. I mean, for the most part, most of the people weren't coming to us until they were in a system. And that's just kind of the way things have worked over the years is, you have a parent call and say, oh my gosh, my kid's, really struggling, but I can't really motivate them to come into treatment. And you say, well, if they get on probation, maybe compliance will be better. But that's the reality for a lot of people. The system being involved, and I think now finally, not the government, policies at all levels are recognizing, we want to be able to get people, we want to be able to do prevention, we need to be able to do front-end diversion, and obviously support programs that we know work, like drug court, medication-assisted treatment. We have to look at housing first, employment first. All of these programs and protocols that we know that are out there, but truly meet clients where they are, and their level of readiness. Because somebody who's maybe shooting up IV heroin every day isn't ready for an abstinence-based treatment, but would be interested in having a safe place to sleep. I mean, that might just be where we start with that individual.
Yeah, that's what I was gonna say. I know that I try to get sober plenty of times, and I would go to like 30-day treatment centers, and you go there and you don't have anything, and then you leave and you go right back to the same thing.
Right.
You're not changing anything. So I tried that several times. I think I was in the recovery house 9 times. That's just
9
a little part of
times.
it. That's not even counting the treatment center. It's just in Bloomington, because I didn't know what to do. The last time I went to jail, I remember getting out and thinking, what do I do here? So that's whenever I ran into a friend that showed me where Peer Run was, and I applied for the job there, because once I did that, then I started getting support, and I started being able to reach out and talk to people. Because if I wouldn't have done that, then I would have went back home and I would have stayed in my room and been depressed till I used again. But I had people get on board and help me, because you got to change every aspect of your life, and you have to change people, places, things. So I feel like once I got help with that job, it gave me, some confidence.
Can you talk about that job, the Peer Run program?
It's a partnership between Centerstone and the city of Bloomington, and I worked for the parks. The first year, it was just the parks department cleaning up like 6 parks. But since then, it's...
And just to describe it a little bit, it was a program to say, people who are homeless, we want to be able to give them a job. And the city of Bloomington was saying, we're having a really hard time filling these positions. So it was really a supported employment. So we had a staff member who was with them, and people were just getting clean and sober, at that point in time, or looking for housing or whatever. But it's one of many examples
So that's
of
a job
meeting
you
people
did.
where they are. Yes.
And we started off with a team of about 10. Was there like?
It never was.
It never was 6.
We aspired to be 10.
Yes.
Yeah, it was like 6 or 7, I think, but only the first year, only 2 of us made it, me and another guy. And so
Without relapsing, you mean?
No, without relapsing, and we didn't quit or get fired or miss days.
And you could relapse. I mean, it wasn't so
You
much.
could do that though, if you just reached out and talked to them and said, I need help. Now, if you just did it and went on and continued your life, you got fired.
Sure.
There's
If you didn't show up
consequences.
and do your job.
But we succeeded because we had good people. Like she said, we had a staff member with us, and we would talk about our problems. I know that Linda helps me with housing. She worked with us one day, and I was talking about I didn't have housing, so she reached out and helped. They're just not a treatment center. Like, they're helping with every part of your life.
Yeah.
Well, I'm sorry, I didn't mean to interrupt, but it talked about that isolation. It brought people out, and so there was a connection, and people were able to get the help they needed just through normal conversation.
Yeah, and that's why I said it's not about picking up trash. It's about them seeing you do it. It's about seeing change in people. Like, I'm from Bloomington, so people see where I'm at today, and they're like, oh my God.
So you're our example.
Yes.
Yes, which is so powerful
Or
because
like saying, how do you get there? Like, how can I get a job? Like, what do I need to do?
You know what strikes me is all very common sense when you think about it.
It
Gee,
is.
you get out of jail, you have one kind of life, you need a little support in finding another kind of life. You know, it just took us a long time.
I know, I'm like, God.
You know what I'm saying?
No,
Just
it is.
blows my mind sometimes to think, gee, this is not that
That's all I
hard.
had to do.
Nor is it all that really expensive or complicated, it's just.
Yeah.
But it
Yeah.
does require a partnership. I mean, I
Yeah.
think that's the thing that's really different,
Sure,
is
yeah.
people kind of
Yes.
getting out of their silos and their typical funding silos to say like, we have a need, we need employees, this isn't terribly hard work, but it could be really
You
meaningful.
know what,
for
where I
someone.
think this brings up though, is one place that I've found is very, very, very important that needs to change deeply, and without it, I do not see how we can get away from this, and that is in the way we run jail.
Yeah.
Jail, I've spent some time in northern Kentucky. Kentucky's done a lot of change in how they do jail in certain areas. And in Kentucky, I'm spending time in Kenton County Jail, which is right across from Cincinnati. And they have a whole new pod where basically they repeat what they would find at your center, but it's for, and it's.
We have a jail program
Yes,
going on
but
now.
this is, I don't know how you do it, but here it's 24 hours. You don't leave or recover. You're always working on your recovery, waking up, making your bed very neatly, and then you're going to class, you're doing all this stuff. And then what they figured out, of course, probably knew but didn't have the political ability to accomplish until recently, is all this reentry. You leave jail. See, jailers for years just say, okay, you're out of my jail, I don't care.
Right.
You're gone, until I see you again, which was gonna be probably in 6
I need
months.
to be back.
Yeah.
6 months later, hey, yeah, what are you doing, you failure? Well, now they're figuring out, well, yeah, but what you also need to do is transform jail. Jail needs to be done in a radically different way, because it's been part of the problem of crime, and it's been part of the problem with addiction since forever.
I totally agree.
And then you do that, change jail in a root way, in a fundamental way, but then you have to provide just exactly what you're talking about, Tammy, which is all these community services, and then it still is not perfect, but it's you kind of, you're getting there, kind of, you know?
Like, you know that you're going somewhere. Before, like, I had nowhere to go, I was just
Right.
lost. I'm like, I don't know what to do.
I'm glad you bring that up, because we actually do have a partnership with the jail here, where we have a 12-bed pod for men, which is 24/7, exactly like you talked about, 90 days while they're in the program, and a 5-bed pod for women, which is small. I mean, we know that
Sure.
needs to be bigger, but again,
You
trying to
start
get
somewhere.
funded for something like that is definitely
What they found in this
a
one
challenge.
jail is it's actually, overall, it's actually cheaper to run the jail that way because the inmates are buying in, they're cleaning. There's not many fights, there's less contraband, weapons are not as common. Which is not to say there's no problems, there's still problems, and they're serious, but it's like this new way of viewing jail that when you think about it, with addiction and crime, both are exacerbated and fomented by the way we've done jail up to now. If you can
Absolutely. There's a lot of trauma.
break that somehow, which is what my next book is about, grassroots responses, and one of them's going to be about how jail might be changed. And just kind of what you're referring to, I think.
Yeah, I think if you go off the street, go in jail, same craziness in there, you know what I'm saying? You're doing nothing, and then when you're getting right back out, it's just the same mentality. You've got the same mindset. So I just feel like you're not going to get any different. You know, if you're in there and you can learn stuff and be productive, you
And
know,
then
you
follow
have a better
that up.
shot of coming out here and being productive. You know what I'm saying? Like you're learning how to live
And
your
I
life.
think essential to that is that you're not just left to go on, you go through that a program like that,
Yeah,
and then you're not
because
just
people
left to
care.
go, okay, you're out of jail and I still don't care about
Yeah, because you
radio.
have corrections officers, you have people that are running those programs that care about you, and they're
Yeah.
gonna set up a plan for you whenever you go. I know that that's what they do here.
Yeah,
Um,
and Linda and Beverly, you all have been exploring a whole other option that I think we should really bring up that seems very on point, and I think it's a model you've described in the book. Can you talk about some of the
So I'm assuming you're talking about the law enforcement assisted diversion program.
Exactly,
Crisis
yeah.
diversion
And
center.
crisis diversion center. And so, yeah, so Linda and I have been with the team that have been working on that and looking at other models in other communities and hoping to even keep people out of the jail system that don't need to go there. If we can direct them to services and treatment prior to arrest, then maybe we can get them to be contributing members of the community in a different way. And so we've also looked at a crisis diversion center, and don't have it yet.
Yeah.
But we're close.
Yeah, we are.
We are. but we're looking at space and looking at, how that would be set up and run. Linda, you may know more about the internal workings of it, but.
Yeah, well, so we went to Fayetteville, North Carolina to look at how they're doing the law enforcement assisted diversion program. And I think one of the things that we found that was particularly striking is a lot of the people that needed to be diverted were people who would touch the jail again and again. I mean, kind of like what you were talking about, Tammy. It wasn't, kind of their first time, whether it's the jail or the emergency department. And we're so fortunate in Bloomington to have a very progressive police department that does a lot of community policing, works very closely with us and other providers to ensure people that don't belong in jail don't end up in jail.
To give services.
To
and
give
make those
services,
touch
to make
points.
those connections. But, in the middle of the night, somebody calls 911, there's not necessarily a place to divert people to. And who LEAD was working with there were a lot of people who were in and out of the system to say, like, okay, let's come up with a different plan for you. So I think what we found is that in order to do the law enforcement assisted diversion well, we need to actually have a place to divert them to that is not the ED or the jail. And so we've been looking at some locations and again really exploring some options. And I think the other thing is Bloomington has been doing a lot of prosecutorial diversion, a lot of work just around bail, to make sure that
and
isn't
law
an issue.
enforcement diversion with our downtown resource officers have been doing that as well. So.
As well as, we have 4 problem-solving courts. So we definitely have a lot of resources and a very progressive community that I think is trying to respond. And we haven't really talked about the needle exchange either, but, that is obviously a big issue in Indiana, as evidenced by the HIV outbreak in Scott County. I know you were down there last year. And, that was the first place that we were able to get a needle exchange, but that has been absolutely huge in our community in terms of harm reduction and,
What do you think about that?
sexually transmitted.
We should call it the Indiana Recovery.
I think it's great.
Why?
I just feel like that it's not just about needles, it's about them coming together with the community and making changes for people. They reach out, they help people get in treatment.
But that's an essential part of a needle exchange thing.
Yeah, it's not about, people are like, oh, they're giving out needles. No, it's not about that. If you knew what they was really doing, like they take their time, they work with people. They're teaching you how to safely use them. They're teaching the community how to help somebody if they overdose. Like they do stuff, like they're not just handing out needles. I know my daughter is now a recovering addict, and I know that they helped her. They got her a scholarship for a 6-month treatment program, and she's been doing amazing since that. So I just feel like that they're.
I think part of needle exchange makes it controversial is like methadone clinics, like a lot of stuff. It's how you do it, and sometimes it's been done very poorly without that component you just mentioned. But other times it's done very well and is essential to keeping a lid on Hep C and HIV explosions.
And one of the other things, I think some of the supportive things that they do, just warm socks, clean warm socks, blankets. When they find people out on the street, it's not just a syringe that you need. I mean, it's not just one thing. You need a whole host of things. And so,
what's interesting to me, Beverly, is on all this is how common sense and obvious all this stuff is. It's like, you just don't need one thing. This realization came to me early on, midway through the book. I was like, actually, it's this, all these things need to be happening, and yet in our culture, it's like somehow a revelation when you say it.
Yeah, well, that's true.
It is.
You're right. And you don't know how far a warm cup of coffee will go.
Or
Oh, that's so
Conversation. Conversation.
Connection.
Right, exactly.
And making that connection and then making another connection, and before you've got, a circle of people.
But what that shows, I think, is what I was saying earlier, is that at the root of all this is a profound isolation in almost any form of life, in a facet of life in America today you want to mention. Professional, political, cultural, neighborhood, on and on and on and on and on. You see this inability to see that if you work this way, it doesn't really go very far, and when you work this way, it actually all these ideas suddenly become like, yeah, duh, this whole thing of you don't know how far a cup of coffee, that is such a beautiful distillation of the whole idea, which is what could be more simple than a cup of coffee, and yet it just seems to have a ripple effect that is maybe profound almost.
Well, Yael even talked about, we're battling this global phenomenon, but we're doing it one person at a time.
Yeah.
And you've got to do it one person at a time.
In fact, there's no other way to do it. In fact, we are in a situation now where we have drug trafficking groups in Mexico and China, maybe other parts of the world as well, I'm quite sure, who behave like multinational corporations with sophisticated ability to shift production and marketing and distribution in ways that when I lived in Mexico 10 years, and I always got used to people from the drug trafficking world being kind of like hillbilly types, yahoos, shooting the guns at 3 in the morning after the party, that kind of thing. That's not who they are anymore, and we live with that. That is a constant. That is something every policy has to take into account when it deals with this in this realm. And I think that's why focusing on strong communities and not on whatever drug happens to be coming down the pipeline is really the issue. You cannot say, well, now we're going to deal with opioids.
Right.
Oh, yeah, here comes meth. Here comes meth.
Well, yeah, because that's what
do we do then? There's no medically
actually,
assisted
we
treatment
have
for
a
that.
question about meth here, so can I put that to the group? All right. So Morgan asks, earlier this month, NPR published a story highlighting, quote, another epidemic that's been brewing quietly but vigorously behind the scenes, methamphetamine. As communities become more and more hyper-focused on the opiate epidemic, how do we ensure that we are providing resources and passing legislation that supports all people experience substance use disorder, not just those using opiates? And
I would say that a lot of what we were just saying is to understand that we are not in I may have started my research thinking of an opioid epidemic, addiction epidemic, and now I'm just thinking of an addiction epidemic, and so coroners are finding in toxicology reports people dying with 4 and 5 drugs in their system, Xanax too, and THC from marijuana, all that other stuff too. And so I think, again, it's getting back to the focus has to be on creating and cementing community alliances, ways of working that naturally reach out to a wide variety of people. For one thing, for example, and this is a big part of what I'm writing in my next book, one example would be churches. Churches have been great for years at dealing with people, families where a kid has leukemia, the father has an injury on the job, can't work. Churches do a magnificent job of coming together to support them. They don't do a really good job when it comes to rape, sexual abuse, child abuse, and addiction now.
Because of stigma?
Yeah, and they don't know how to talk about it. What do we do? They're not trained in that. There's a lot of reasons.
Swept under the rug.
Sometimes, and so.
Well, it's weighing the moral, physical issues.
All of that is part of the mix, but I think a crucial component in all this is that churches need to be involved, because so much of what goes on in a church has helped to stifle the discussion of this. And if you look at where this opioid epidemic got going first, it's in very, very heavily churched areas. You're talking about Appalachia, you're talking about West Virginia, Kentucky, Tennessee, Indiana. All these places have lots of churches, and churches were maybe even part of the silence problem, if you ask me, frankly. They need to be brought in. That is where community is created every Sunday. It's not like it would be nice if they did this. Absolutely, they have to be part of it, and they have to understand that their role is essential in creating the problem, and essential and beautiful when they can be part of the solution. And so it's using the community approach to not worry about, is it heroin today, is it fentanyl today, is it pills today, is it meth? It's all an addiction, and it all is treated. You can't treat methamphetamine with medically assisted treatment with Suboxone and Vivitrol. You can treat all of this with a community strength.
I would really love to know from your perspective, you talk a lot about the undoing the silence and how that played a really huge role in a lot of these communities, the Solace group, for example.
Yeah, sure.
Are you seeing families being forthcoming here about this problem? I mean, you are super brave coming, talking about, being vulnerable. Are other people like you? Do you see a group of families coming together to try to work against this problem?
Yeah, I do. I see a lot of people. I work with a lot of people daily that want help, and they come in and they ask for help and they want to make changes in their life. I also see families that, like me, I had to leave most of my family because they're drug addicts. You have to separate yourself because, like you said, you have to start one person at a time. You have to help you. But I've also known, like, me getting sober and leaving my family, I've been able to help them now. A lot of my family have got help now. And
Great. Yeah.
Like,
That's what happens. You begin to see the
It's
example.
contagious both ways.
No, I believe that's also,
Yeah.
it was a contagion of addiction, almost like a disease, kind of a virus.
yeah,
And now
my
it's-
friends, like people I grew up with that have been on meth, heroin, whatever drug it might be. I don't look at the drug, I just look at you need help. So I've just seen, I can't believe the turnaround, like
Really?
the people that are getting sober today, I'm just like, it's amazing.
Yeah, I mean, and I really
That's
do
so
think
interesting.
the focus has been on building community and building
Yeah.
community partnerships across the board. I mean, because if you look at even the faith community, in Bloomington, we have the Interfaith Winter Shelter, where
Mhm.
churches have really come together to
Yeah.
ensure that, homeless people have access to at least a safe place
They
to
can
stay.
pick them up to take them to church.
Right,
They'll
but-
call them like, want to go, like.
And
so
then
they are
we have
set up.
like the Recovery Engagement Center, which is a
Yeah.
drop-in center where, regardless of whether or not what you want, you can come get a cup of coffee and you can talk to someone, and kind of figure that way through. But I think the point of, recognizing the vulnerability of our people, and that was one thing that we haven't mentioned yet, but was a real eye-opener for me in your book, was how people are specifically targeting the most vulnerable people, whether it's people at methadone clinics or people, standing outside a treatment center, that we have to really have a community to support people. We have to have the Tammys who are willing to be brave. And in every church, people do have stories that they can share. And a way to start making kind of the flip side more transparent and open, because there is a heck of a market we're going to have to continue to deal with.
Yes,
Yeah.
I think that's true, and we need to understand. I think, for example, I get back to churches just because I noted midway, not too long ago, you think about it, I was in Eastern Tennessee, the Bible Belt, in my opinion, and man, bad problem out there. Well, why would there be a bad problem if there's so many churches? Wouldn't that be the community that you would need to keep people from this? And turns out not. And I think one of the reasons is because people in church, part of it is they don't want to deal with this, but then also I would say this, a lot of addicts don't believe they belong in church. They feel ashamed, like I'm dirty, or I'm not good enough to be around these people, and they may not look, they may smell, they may have, the effects of living on the street, So.
I think I started going to church, remember I got sober, a year into it, and just how uncomfortable I felt, even though I'd been sober, I just felt uncomfortable and out of place.
Was that you or them?
It was me,
Yeah.
it was how I felt about myself, I believe,
Yeah.
because they were so welcoming to me, they wanted me to be there. I think we have to learn to love ourselves and
Yes.
care about us and think that we deserve something.
And don't you also think maybe it's also learning to be around people where
Yeah.
addiction is just all about me being alone and my own self-gratification?
Isolating, being alone, or you're around those, the people
Yeah, you
that
have
are
to have
used
some
to
positive
living,
mirrors.
Right.
You're not used to communicating with those, the
Right.
people that are normal.
Part of one woman told me recently, actually a couple of days ago, in a parking lot in West Virginia, part of what I needed to learn was how to relate to other people, how to save money, and how to be on time to a job. These kind of basic individual kind of
Common sense.
Skills.
common sense,
Yeah.
but also things that we all learned when we were like 15.
Yeah.
First job, you learn, you better be on time, you're gonna lose a job. Well, she was high
Right.
for,
And
18
her
And
mom
that's
was
where
I've
brain
heard that
comes
lots.
into it. Yeah.
Well, when you start using your mind stops growing, you don't develop, you know what I'm saying?
Sure.
You are like at that age, and I know I was there, you know what I'm saying? When I got sober, I'm like, no, my kids knew more than me, so, you know what I'm saying? And it's embarrassing kind of, but if
But you gotta work through that.
You do,
And
and you gotta learn to grow.
Kind of going back to what you were asking before, Yael, in terms of, what do we do as a community, it is sort of recognizing, again, what is most important to that person? It may
Yes.
not be being clean and sober. It may be, I need to have a safe place to live. And looking and helping work them with housing, and then, you know, what comes next. So my kids, you know, so it really, what's a priority for each person is really different. And I think having that flexibility to work with them, but also to take our services from sort of behind the walls out into the community. How do we support people in real time? How do we show them? Yeah, well, an important life skill is showing up on time to work. If you don't show up on time every day, what are the consequences? And actually helping somebody work through that, or you know, they relapsed last night, and so they don't feel like they're worth it coming in today, and going out and, you know, working with them there. So I think it's a flexibility in terms of the way that we work, and a recognition of the disease that this is.
No, not a one size fits all.
Exactly.
Meet people where they are.
Yeah, there's a lot of different personalities. There's just a lot of different issues. There is.
Yeah, sure.
Like working there, I'm just like, it was different. I get used to it, you know. And people's demands are different, you know. What might help you today ain't gonna help you, you know. So it's been a journey, you know. But it's been amazing I love it.
Well, thank you for sharing it with us. And thanks everyone. We're coming up on 1 o'clock, so we should probably wind our conversation up. But there's more. You can hear more of Sam Quinones. No, Sam Quinones.
Yeah.
Quinones. No,
Sam
Quinones. Sam right here will be talking about his book, Dreamland, and much more tonight at the Buskirk Chumley Theater at 6:30. Please join him for this. You can get your tickets through the Buskirk Chumley box office. I think they're still available.
There's a
A few,
Not
just a
all.
few.
So,
And it's free.
And it is free, that's right, at bctboxoffice.org, I believe. Thank you so much for joining us today, Linda Grove Paul and Tammy Hooten from Centerstone, and Beverly Calender-Anderson. I'm Yael Ksander. Thanks a lot, and we'll see you next time.